the next speaker will be Dr. Professor Atef Radwan, and he will be talking about hospital preparedness surge plan in COVID-19 pandemic. Professor Atef, he is a consultant and head of the Department of Intensive Care Unit in Al Jof, Saudi Arabia. Please, Dr. Atef.
Assalamu alaikum. Did you hear me?
Dr. Atef, are you around?
Yes. Can you hear me?
Yes, please go ahead.
Bismillah ar-Rahman ar-Rahim. Before I start my presentation, I would like to just to say this is Professor Della Corte from Italy. He was supposed to share with us in this conference, but he apologized. He was febrile in the last week. I hope he is safe and healthy, and I hope for Italy the best, inshallah. We'll be talking in the next 20 minutes. The voice is clear?
Yes, clear.
Okay.
Clear.
Yes,
Yeah.
Please go ahead.
We'll be talking the next 20 minutes about hospital preparedness surgery plan for the COVID-19 or the pandemic. As we know, all the disaster by definition, simply it is a load capacity imbalance. The load represented by the number of cases, the influx of cases, and the severity of cases. And the capacity determined by many factors inside the healthcare service. If this is the capacity, we have to expand our capacity, and we have to decrease the influx of patients, and to increase disposition from the hospital load in the hospital, and decrease by social distancing to decrease the influx of large amount of patients. Because as we have seen in the many scenarios in Europe, the overloading of the hospital can increase mortality because of lack of the resources. It's simply the capability of the medical system to cope with the sudden or sustained increase in the load. You have to increase the space, the rooms for critical care patients, for severe cases, for mild cases. You have to expand the capacity and capability of the staff, healthcare workers, the supplies, especially the personal protective equipment, and the system operating inside the healthcare service. The main bottlenecks or limitations in the management to increase capacity inside the healthcare service is the ventilators, the ICU or critical care rooms, and the isolation rooms, the personal protective equipment and the other equipments, and the logistics and the infrastructure and the financial issues. The purpose of this talk is to describe a stepwise approach to critical care service expansion in response to the pandemic. Specifically, we should know how to calculate the load capacity balance in hospitals. We should know how to escalate and shift between the conventional care or phase to the emergency or contingency phase, then to the crisis or disastrous phase. How to shift from this phase to the other phases. We should know how to plan for the target, to define our target. What can we tolerate inside the healthcare service? How to integrate between this continuum between the hospital and the department of the hospital, and between hospitals and the state and the national healthcare work and other services. What are the principles of surgical capacity planning? And what is the main tools and strategies to implement the preparedness surgery plan? There is an important concept called the turning point between the accident and disaster. To convert into disastrous situation, should know your turning point, the hospital turning point or the healthcare service turning point. Because this turning point where you should declare beforehand disastrous situation, and if it improves, you should plan for recovery and restoration of the institute function. It is calculated by the number number of cases multiplied by the severity in relation to the institute capacity. So we have to estimate the number of casualties, have a calculator for the medical assistance and chain in the healthcare service. How to estimate the number, as we know all that epidemics and pandemics have the enormous number and enormous disaster severity scales compared to other disasters. There is multiple mathematical models which they can predict from the community, from the recovered cases, infected cases, and susceptible cases. They can predict the evolution and the behavior of the virus when it will peak, and this helps us too much to plan beforehand how much we need to surge our capacity when we have to plan for recovery and restoration of the hospital function. The severity is simply the ratio between the hospitalized patients and the non-hospital or ventilated, potentially ventilated patients, and T2 is the stable patients which need just oxygen therapy over the non-hospitalized or T3 patients. This is the definition of the severity, the number of admitted patients to the hospital in relation to the number of the non-admitted patients. And this helps us to plan how much we need rooms, how much we need PPE, how much we need staff, etc. From the colleagues in the first presentation, our colleague from China, they put a very important estimation or very important statistics between, for all diagnosed cases, 80% is mild to moderate, severe cases is 15%, and the critical cases is 5%. This helps us if we have, for example, 1,000 cases in the state, in the city, we can estimate, predict that we will need 5% ICU beds of this 1,000. So we need 200, and this is very enormous. And you have to plan beforehand to increase your capacity to the maximum and to collaborate with the other institutes. Regarding capacity, there is three links or three chains of the medical assistant chain capacity. The pre-hospital service, this is very important to decrease the load to the hospital. The transport distribution, you have to distribute the disaster for many centers to decrease the load over the, not only on one healthcare center. And the hospital treatment capacity, you have to escalate the staff number and quality, the material, and the procedure, etc. You have to be ready before you receive patients. This is one example how to patients. What is the performance of these institutes? This is regarding personnel, material, and protocols. If you don't have staff available, inadequate number of staff, you will take 20% readiness. If you have staff being available in number, but not qualified, you have 40, etc. If the staff available and they trained at attending drills, this is 100%. So both our estimation is 80% here regarding the personnel, and it is 4% in the material, and 80% in the methods, in the action plan, the triage protocol and treatment protocols. So the weakest point will be in the material. So your capacity is 40% only. You have to plan to increase this capacity towards the 100%. So the turning point is between the capacity, the load capacity imbalance, how to escalate your readiness from how to shift from the conventional to contingency to crisis phase. This is an example from our center. You have 5 ICU rooms, negative pressure rooms or normal pressure room with HEPA filter. In the contingency plan, we need to increase it to 15. We can increase it to 15 by preparation of the isolation department with HEPA filter. And in crisis phase, we have to recruit staff and rooms from CCU, from cardiac surgery ICU, from the OR suite, recovery area, and then to use At the end, the unit open area in ICU have 25 beds open area in ICU you will be utilizing, and this needs special precautions and prolonged use of PPE being an open area, which might increase incidence of infection to the staff. In the convention, you are depending on your critical care staff. In contingency, you recruit from the other departments, from anesthesia, from internal medicine, from CCU, from the surgery. Now we have trained all the internal medicine staff on the basic critical care skills and infection control standards, all the infection control standards, including the PPE, practicing, etc. In the crisis phase, we have to plan for recruiting staff from outside the institute, and this need multi-agency agreement during the preparedness phase. Recommendation from Robinson 2008 is to have at least 300% increase in the critical care beds beyond the baseline. But as I have seen the scenario in Italy and China, you may use open area, you may use field hospitals, etc. And this might not be sufficient even in case of this catastrophe. Actually, you plan to increase the capacity by 20% in the usual phase. In contingency, you increase it by 100%, and in crisis, you increase by 200 to 300%. But I think this is not so practical. You have to plan for the worst. And you have to integrate by mutual agreement between the departments and between the hospitals in the area and the national service. What are the principles of surge capacity? How to expand your capacity regarding the staff, supply, and material? You have to plan for integration between the chain of surge capacities. You have to offer a centralized response if you have scattered zones or areas of outbreak. You will be obliged to use another standard of care. You have to alter the standard of care to use what is available, and we can call it the damage control philosophy. You keep some resources and standard of care to the most survivable patients. And you have the principle of reverse triage. The reverse triage is to select the healthy patient, the recovered patient, and for early discharge from the hospital to dispose to other healthcare service with less critical care, and to do compartmentalization that I will see. So you have to integrate between the levels of care, between the pre-hospital care, the transport, the ambulance service, and between the hospital service. You have in scattered surge capacity, you have when the resources are low, you have to centralize your response to maximize and to redistribute, reallocate resources among the areas of outbreaks. You have to change, or you'll be obliged to change your standard of care in constrained resources. But this will have a social concern, as this will be ethically difficult. They call it the age of intubation, the new intubation for certain ages, and this will be difficult ethically for especially for the society. They will stigmatize that as failure to provide appropriate care for our patients. There may be no other way, and when you don't have other way for reallocation of resources for certain patients, we call it damage control philosophy, or choosing the lesser of two levels. You have to start to do the adapt in contingency standard, to adapt to some standards, to reuse and restyle some equipment, and to reuse N95, for example, etc. And the crisis standard of care, you started to use the triage, which is very difficult ethically and psychologically. You do triage, you do best for the most. You choose the one who is terminally ill, is not going to be outcomes, and they are using futile therapy. So in triage concept, and this is multidisciplinary meeting, multi-consultants, not a single person decision. And once the The disaster situation finish, you have to return back to the appropriate standard of care as soon as possible. One of the methods or strategies to increase your capacity is to triage certain patients to be admitted to the hospital. Don't admit all patients to the hospital to overwhelm the institute, and early disposition with certain categorization to dispose patient out of the hospital in certain low critical care centers. So it is safe discharge of the current inpatients and refocus of hospital resources to those in the greater need. Another way to decrease transmissibility of disease is to compartmentalization of patients with their staff. You have to assign some staff for COVID and some staff for non-COVID patients to decrease transmission of infection. And you assign, as we have done in preparedness plan, you have to assign the medical people, the non-critical care staff trained with basic skills to non-critical COVID teams as non-COVID teams, and keep the critical care, which have a shortage, of course, especially regarding nursing and critical care, to assign them to the critical COVID team. This will help us too much to take care of the most needed patients. What are the main tools to implement such a surge plan? The SBSR, or this is from SBCO of American Heart Association.
3 minutes.
It is
3 minutes, the professor.
Okay, Dr. Ali. Okay. You have to have a system of thinking. You have to offer a good structure regarding people, education, training, and equipment. You have to have a process, policy and procedures, guidelines, and you have to implement some programs, training program, standard of care in each link of the medical assistant chains. You have to have a protocol about the disposition classification system, which patient can be discharged first and so on. And you assess your readiness if you are affording your capacity, the capability, the skills of the staff, and if you offer all about the safety, which is the most important factor regarding healthcare worker. You should have a structured approach to release the surge capacity, like CSCA-TTT of Advanced Life Support Group UK, command and control, safety, healthcare worker and patients, communication of among all stakeholders, assessment and anticipation of the influx of cases. And this is a dynamic situation through dynamic situational analysis, and you need to follow, and you need agile leader. These he can follow the changes outside them and they can plan accordingly. The triage and reverse triage and the treatment guidelines should be all available and transport between inside the hospital or among the hospital in the and the most important factor in any disaster situation at the hospital, incident command team. This is the basic command team, the hospital coordinator, the medical director, the nurse supervisor, and the management coordinator. And the most important team is the outbreak response team, the infection control, and the clinician, etc. To summarize, we have to anticipate the load and estimate it a little bit accurately. So you have to segregate patients with their teams inside the hospitals. You have to escalate. You should have an escalation plan to release all the endogenous surge capacity regarding the space, staff, and supply. And it is surge capability also, not capacity. Capacity means the number, and the capability means the skills like training, drills, and the functional exercise. And you should have a disposition classification system protocol. And the surge tool, system of care, the structured approach, and the incident command team. Thank you so much.
Thank you so much, Professor Atef, for this presentation. The next